Obsessive compulsive disorder is a severe and debilitating anxiety disorder affecting about one adult in 40, making it twice as common as schizophrenia and bipolar disorder, and about the fourth most common psychiatric disorder. OCD exists throughout the world and affects men and women at an equal rate. OCD usually begins gradually. Approximately two-thirds of people with OCD develop the disorder in adolescence or early adulthood. The impact of OCD on a person's quality of life is strikingly high. Every aspect of a person's life can be affected, including the way the person thinks, feels, and behaves. The intensity of the symptoms can range from mild to severe, and the symptoms usually wax and wane over time. In severe cases, which may define up to 20% of those with the diagnosis, obsessions and compulsions can occupy the entire day and result in profound disability.
All right, time to go home. Okay, let's stay on the black. Stay on the black. Step, step, step. You got it. Stay on the black. Stay on the black. All right, where's the button at? All right, keep it even. 1, 2, 3, 4. Stay on the black. 1, 2, 3, 4. All right. Step. Keep staying on the black. Oh, she just stepped on the white.
The first predisposing factor for obsessive compulsive disorder is the environment. People who have experienced abuse, whether physical or sexual in nature, especially in childhood or other trauma, are at an increased risk for developing OCD. And in some cases, children may develop OCD or OCD symptoms following a streptococcal infection. Another predisposing factor for OCD is genetics. Twins and family studies have shown that people with first degree relatives, such as a parent, sibling, or a child who have OCD, are at a higher risk for developing OCD themselves. And the risk is higher if the first degree relative developed OCD as a child or tween.
Oh my gosh, who left the library like this? Now I gotta fix the chairs. Oh my gosh. I tell you, people. Alright, let me. Five. What happened to these books? Who left these books like this? Did she do? What? Oh, now I gotta fix the books. Okay, put these chairs back in. Put these chairs back in. Alright, chairs, they're all in. 1, 2, 3. Straight. Are you straight? Is it straight? Straight? No, it's not straight. It's crooked. It's crooked. Okay. One more book. Alright, Jalen, just breathe. Okay, you're on top. Go straight. Okay, is it straight? Straight? Oh, what's straight? Straight, is it? Oh, okay.
There are some common obsessions that come with OCD. One is contamination. It's the fear of contamination by dirt, germs, or other diseases. For example, by shaking hands. There's also a fear of own saliva, urine, feces, semen, or vaginal fluids. Another one is repeated doubting. It is the fear of not having done a specific act that could result in harm. For example, turning off the stove, hurting someone in a traffic accident, or leaving the door unlocked. They are scared of making a mistake. Another one is ordering. It's the fear that things will not be just right and become distressed when things are shifted or touched. There are also compulsions that come with obsessive compulsive disorder, such as cleaning or washing hands too often or in a ritualized way, showering, bathing, brushing teeth, grooming a lot, or having detailed toilet routines. There's also checking that you don't harm yourself or others, checking that nothing terrible happens, checking that you don't make mistakes. There's ordering or arranging, making sure things are just right or consistent with a specific rule, such as bed sheets or notes on the desk. And the last thing is hoarding, is collecting seemingly useless items such as paper, magazines, towels, bottles, or pieces of garbage.
This table is filthy. The book is filthy. The chair is filthy. Good thing I carry my wipes around everywhere. Okay. It's dirty. My hands. I need to wipe them off. In the book. Who knows what's been on this? It's filthy. It's dirty. The chair. Over there. Okay. I guess I can touch it now. Okay. Chapter 10. All right. Let's get to working. Hey, is that Kamari? I'm sorry. I just can't. No, I'm sorry, but What's wrong with me? I couldn't. His hands, who knows where they've been? I need some hand sanitizer. I didn't even touch him, though. I just can't. I gotta go. I can't do this anymore. Oh, I touched a bookshelf. Oh, my hands. Wipe. Okay. I gotta go wash my hands.
Treatment modalities is marked by, first, individual psychotherapy, which allows the client to discuss their anxiety with their therapist, and this will usually lessen their anxiety. The next up is cognitive therapy, and this is a little more structured than the individual therapy. It usually involves homework assignments, but it's also a great way for the client to relay their feelings and calm any fears that they may have about treatment. Next up is behavioral therapy, which includes habit reversal therapy, or HRT. There are two types: systemic desensitization, which is when the client is gradually exposed to the stimulus in real life or imagined, and this teaches them to train in different relaxation techniques. Next up is implosion therapy, which involves a flooding of all these different stimuli to the client. That's usually a real life situation, and it is extremely frightening for some clients. And last but not least is pharmacological therapy, which includes anti-anxiety agents. And these drugs include antihistamines, such as hydroxyzine, benzodiazepines, such as alprazolam, carbonate derivatives, such as meprobamate, and azazpyridecanoids, such as buspirone.
Nurses play an important role in caring for a patient with OCD. In most cases, care is sought when the condition has begun to exert a high toll on the patient's ability to function on a daily basis. He or she is likely experiencing difficulty maintaining family stability or performing adequately at work or school. You can support the patient in managing anxiety related to obsession and exhibiting compulsive urges. This includes helping the patient identify situations that increase anxiety and trigger obsessions and compulsions, as well as identifying how the disorder may be adversely affecting important roles and relationships. It's important to acknowledge the patient's anxiety responses and rituals of other compulsions without judging him or her. In almost all cases, a person with OCD will have a great deal of shame about his or her obsession or compulsions. If the patient has compulsions that he or she needs to carry out during contact with you, for example, during an office visit or while in an acute care setting, it's important to give the patient time to perform rituals without conveying disapproval. Gently encourage the patient to speak about the meaning and function of the behaviors. Over time, in collaboration with the patient, you can carefully begin to limit the time devoted to the behaviors and offer positive reinforcement for the patient's success in inhibiting urges to perform these behaviors. When important roles and responsibilities have been adversely affected by the patient's OCD, help him or her acknowledge this impact and identify strategies from improving relationships, enhancing the ability to complete tasks, and maintaining participation at work, school, or in other settings. Involve the patient, families, or support network wherever possible. In many cases, the patient is likely to have become isolated. He or she may be less able to access support networks, and supportive relationships may have been stressed by the disorder.